Okay, let's just dive right into this. Welcome to today's Explainer, where we're embarking on a journey to finally demystify the mechanics and honestly, the profound mysteries of low back pain. If you've ever felt that sudden twinge, that really deep ache, or that shocking zap shooting down your leg, you know exactly how debilitating it can be. But today, we aren't just going to talk about how much it hurts, we're going to look right under the hood. We're breaking down the medical science, the actual anatomy, and the modern pathways to relief. Let's get started. $300 billion. Let that sink in for a second. That staggering number represents the all-cause medical costs associated with low back pain in the United States alone. And that's every single year. It's literally one of the leading causes of years lived with disability worldwide. So we're looking at a massive systemic problem here that impacts productivity, healthcare systems, and just everyday life on an unbelievable scale. But let's bring it back to the human level. The data shows over 57 million unique patient visits happen for this issue. So the absolute crucial point you should take away from this is, if you're sitting there struggling with a bad back, you are definitely not alone. It's an incredibly common human experience, especially as we get a bit older. In fact, between 28 and 34% of Americans have experienced low back pain just in the last 3 months alone. Section 1, the 3 types of pain. To solve any problem, we first have to understand the enemy. And in medicine, we can basically break back pain down into 3 categories: hardware, wiring, and software issues. First up, we've got nociceptive pain. Think of this as your hardware issue. People usually describe it as a deep, aching, or throbbing kind of pain. This comes from cumulative stress on your tissues, things like normal degenerative changes in your spine or myofascial muscle pain. Then, on the other hand, we have neuropathic pain. Now, this is a wiring problem. It's sharp, it's shooting, or lancinating. This happens when there's an actual injury or disease directly affecting your somatosensory nervous system, like a herniated disc physically pinching a spinal nerve. Okay, but here's where it gets absolutely fascinating. The newest recognized category of pain is called nociplastic pain. You can consider this one a software glitch. It develops because of an abnormal processing of pain signals in your central nervous system. So the alarm bells are ringing super loudly, but when doctors actually go looking for evidence of tissue damage or nerve pathology, there isn't any. It's highly associated with extreme hypersensitivity, fatigue, and even psychological distress. The hardware and the wiring look completely fine, but the software, it's trapped in a loop of pain. Section 2, anatomy of an ache. So what does it actually look like when the hardware and the wiring do fail? Let's pull back the curtain and take a look.
Notice the plump, healthy intervertebral disc here. It acts as a perfect shock absorber between the bones of your spine, with a really nice, well-contained center. But as we age and those discs degenerate, they start to lose height. The outer ring, called the annulus fibrosus, can even tear. But here is the really critical detail from our medical sources. Disc degeneration isn't just a mechanical squishing. It actually recruits inflammatory cytokines. These tiny molecules severely sensitize the surrounding nerve endings, so you're not just losing a cushion, you're developing a highly inflamed, biologically irritated zone right inside your spine.
Now, let's view this through the lens of an MRI. We can clearly see 2 different types of severe structural issues that cause that sharp neuropathic wiring pain. First is spinal stenosis, where the central canal itself is physically narrowing, often because of a bulging disc or facet joint hypertrophy, which physically squeezes the spinal cord area. Then we also see a herniated disc, where the inner jelly-like nucleus pulposus has extruded straight out into the central canal. When these structures impinge on the nerve roots, wow, you get that agonizing shooting pain that radiates way far beyond just your back.
Which brings us to a key diagnostic question. Does your pain stay local or does it travel? Doctors make a big distinction between localized mechanical back pain, which usually gets worse with activities that stress your physical structure, and radicular pain. Radicular pain, or lumbar radiculopathy, is that classic sharp pain that travels right down the leg. It often follows a very specific distribution based on exactly which nerve root is getting pinched in your spine. Section 3, playing medical detective. So, how does your doctor figure out exactly what's going wrong without, immediately cutting you open? Well, one of the most classic tools in the medical detective's toolkit is the straight leg raising test. It's brilliantly simple. The patient lies perfectly flat on their back. The examiner then passively lifts the affected leg at the hip. If lifting the leg to a certain angle suddenly reproduces that exact sharp radiating pain down the leg, bingo, it's a massive clue. This test has fantastic sensitivity for detecting an impingement of the L5 or S1 nerve roots down in the lower lumbar spine. But while doctors are looking for simple clues, they're also desperately scanning for red flags. These are symptoms that suggest something far more sinister than just a simple muscle strain or a bulging disc. If your back pain is accompanied by fever, chills, unexplained weight loss, or, and this is a big one, severe progressive neurologic symptoms like losing control of your bladder or losing sensation in your saddle region. Actually, scratch that. Any of these symptoms mean this is no longer routine. These red flags point to potential medical emergencies like deep infections, spinal tumors, or cauda equina syndrome. They require immediate, urgent intervention. Now, assuming you don't have any of those red flags, you might think the very next logical step is to immediately demand an MRI. But let's bust the MRI myth right now. Advanced imaging isn't always the first step, and here's exactly why. The medical data shows a staggeringly high percentage of spinal abnormalities in populations without any back pain at all. To put that in perspective, if you scan 100 random pain-free people, a huge chunk of them will show bulging discs or degeneration. Early imaging often reveals abnormalities that aren't actually the source of your pain, and that can lead to unnecessary anxiety or worse, unnecessary surgeries. The clinical history and the physical exams, those are the true foundation.
Section 4. Pathways to relief. Okay, so if an immediate MRI isn't the magic bullet, what is? Let's explore the incredibly diverse solutions modern medicine offers.
Effective treatment is rarely just one single solitary action. The absolute most successful approaches use a multimodal strategy. You have to attack the pain from 360 degrees. It combines pharmacologic options like NSAIDs or muscle relaxants with psychological support, physical therapies, and, if it's really necessary, interventional procedures. If you're relying on just a single magic pill, it usually leads to failure. You need a comprehensive, individualized treatment plan. And the absolute cornerstone of this multimodal approach, physical therapy. It's not just about resting, it is all about active rehabilitation. Physical therapists evaluate and correct the kinesiologic or functional abnormalities that are putting improper stress on your spine in the first place. Through highly targeted core strengthening, manual therapies, and neuromuscular reeducation, they address the true underlying mechanical causes of the pain. The ultimate goal is to literally build a muscular corset around your spine to support it and prevent future injuries. But what happens when physical therapy and medications just aren't quite enough? Well, that is where interventional procedures come in. Think of these as targeted, minimally invasive strikes. Doctors can use fluoroscopy or ultrasound to guide epidural steroid injections directly into the space around your irritated spinal nerves, bathing them in powerful anti-inflammatories. Or they might use radiofrequency ablation to literally burn or deactivate the tiny medial branch nerves that transmit pain signals from arthritic facet joints. Now, these aren't permanent cures, but they can dramatically calm those sensitized nerves and give you a real window of relief. And then, finally, we have surgery. Let me be super clear about this, based on the clinical sources. Lumbar surgeries, like spinal fusions or decompression, are generally considered the absolute last resort. They're typically reserved for patients experiencing progressive neurologic deficits, like if you're actively losing muscle strength in your leg, or for highly refractory radicular pain that has completely failed to respond to physical therapy and injections. Surgery aims to correct very specific, severe anatomical structural failures, but it comes with its own risks, and it's never a guaranteed fix for generalized back pain. Which brings us to our final and perhaps most provocative thought of this whole explainer. As we discussed earlier with nociplastic pain, the biological damage is only one piece of the puzzle. The biopsychosocial model of medicine recognizes that psychological distress, mood disorders like depression and anxiety, and even our social environments deeply influence our overall perception of pain. So I want to leave you with this question. How much of the physical pain we feel in our bodies is actually being amplified or even generated by the stress in our minds? Understanding that profound connection might just be the ultimate key to true lasting relief. Thank you for joining me on this explainer. Keep learning, keep asking questions, and take care of your spine.